Good morning, everyone. So, second day of Critic, we have some fantastic speakers and very seasoned moderators who's going to talk about very interesting topics today. So, first of all, I would like to welcome our chairpersons on the stage, Dr. Sai Satyanarayana, Dr. Guru Prasad, and Dr. Krishnamurthy. Our first talk to be delivered today is changing definitions of ARDS. How relevant are they? Dr. Pradeep Rangappa, sir. Thank you, sir.
Good morning. So at the outset, thanks critic team of Hyderabad for having me here. It's always a pleasure to be here. So this particular talk was given to me, changing definition of ARDS, how relevant are they? So the answer is yes, they are relevant, and it is important that definitions have to change to adopt to the newer nuances that are evolving in the research areas in ARDS. So why we need the newer definition? What has been the historical sort of a definition? So 1967, Oshbog first came out with the term of ARDS, and he defined the whole nuances of ARDS. And 1988, the lung injury score came in 1988, and they defined as to how you identify the patients with ARDS and what are the criteria that one needs to have to define this conundrum or the spectrum of ARDS. 1992, the US and European consensus, they altered the definition like any other sort of a definition of any other disease condition. And they defined and they put in certain criteria as to how we should define this particular condition. And we were following this. When I was training in intensive care, I used to follow this US and Europe consensus definition. It's called AECC consensus. Then 2012, all the newer trainees, so we're all adapt to Berlin's definition, which we seem to be following at this point of time. That came from the ARDS definition task force. So now why are we here? Why was this topic given to me? 2024 Jan, so the American Thoracic Society came with this new global definition that still needs endorsement. So for all of us here, we still need endorsement to understand whether this new definition is something that we can take into consideration. And we'll look into what the definition should encompass when we define a new sort of a nomenclaturing for ARDS. So the question we need to ask is, why do we need definition change? The meaning of definition is, our definition of any disease condition should be able to consistently and accurately identify the patients with similar characteristics. Try to cohort the patients, group them into similar characteristics so that we are able to perform clinical research and try to understand the epidemiology of this disease burden and globally network and do research and collaborate with regards to understanding the pathogenesis of the disease, then the treatment modalities that are needed for the disease, and the synthesizing and distilling the essence of the trials and outcome prognostication. So these are the reasons why we need a good definition, and what are the key components of this definition, how it has evolved is what we need to see. So the lung injury score that came way back in 1988 came by Murray et al. So this definition of ARDS encompassed risk factors and acuity, because we know ARDS is acute respiratory distress or adult respiratory. It's an acute condition. So acuity was factored in and severity was factored in. So what are the components of lung injury? Just to recall and recapitulate what was mentioned. So they divided lung quadrants. If there is one quadrant involvement, it was grade 1, two quadrants grade 2, 3 and 4, so on and so forth. Then they defined PaO to FI ratio. More than 300 is normal, and as you see the numbers, less than 100 was severe. Even today, less than 100 is constitutes as severe. And they even put PEEP, so correlation to the PEEP and the FiO2, like more than 15 FI PEEP, it would be called as severe ARDS. And they even looked at compliance. So it was a quite comprehensive sort of a scoring where they had a compliance also factored in. More than 80 is normal, so less than or equal to 29 was severe ARDS. So it was a nice scoring. And when I was in Australia, we used to follow this, and then the AECC sort of a definition came. So this AECC, American European Consensus definition, came in 1994. So where they called ALI, they divided into two components called acute lung injury. I'm sure many of our seniors who are here know that I used to like this word ALI, acute lung injury, and ARDS. So we called acute lung injury if PaO to FiO2 was less than 300, and ARDS is a very simple, nice definition. And even X-ray, they said it needs to be bilateral, alveolar, interstitial. They did not try to define it to quadrants. any bilateral alveolar interstitial infiltrates, we can call it as ALI bar, ARDS. And here what they put, because that was an era when lot of PA catheters were used, so they put this pulmonary capillary wedge pressure. Basically, they said they should not have high filling pressure or left atrial pressure should not be high. So there should not be increased left atrial pressure and wedge pressure should be less than 18. So which was fair enough at that point of time. A lot of PA catheters were being used. But there were limitations of this AECC definition because acuity, they did not define when do you say it's acute, whether 1 week or 10 days or 5 days. So that was not well defined in that. And this PaO2 FiO2 could be manipulated by PEEP because after AECC, multiple studies came which said you increase the PEEP, so then you can reduce or increase these PF ratios, and then it will become an outlier when you are defining this ARDS. I'll show you some of the studies. And this bilateral alveolar interstitial infiltrates was a little vague and it was very subjective. It was left to a subjective interpretation and it became little unreliable. And this wedge pressure, all of you present here knows it is amenable to therapeutic modalities and it can oscillate. So you can have one reading more than 18 and after that you can have at around 12 after you have given diuretics, so on and so forth. So not consistently it remains high and there can be false elevation of pulmonary wedge pressure or left atrial pressure. And acute lung injury was used very loosely, and I used to love using this acute lung injury. Any patient who has some hypoxemia, we used to call it as acute lung injury. So it was used inconsistently. And these were some of the limitations of AECC definition. So this was a study that came from Argentina in 2003, which first refuted this AECC definitions. If you see at the PEEP of 0, they constituted patients as ARDS, but after 6 hours of PEEP of around 11 centimeters, so they had PF ratio of more than 200, which means they fall in milder ARDS. And after 24 hours of PEEP, 62% had PF ratio. So which means with PEEP manipulation, you can sort of outdo the definition or outdo the categorization of the severity of ARDS. So that became the sort of criticism. And this was a Canadian paper in 2002, which said that 82% of anyone who you see had a wedge pressure of more than 18 millimeter mercury. And that sort of created as a confounder when you're defining these patients with ARDS, and you captured a bigger sort of a population, not necessarily would have fitted into ARDS. So these were some of the limitations of the AECC sort of a definition. Then came this Berlin definition, which we all seem to be following at this point of time. Here Berlin definition put the acuity because the AACC said acuity, here it said 1 week. So it should be less than 1 week after the trigger when there is a worsening hypoxemia or worsening respiratory symptoms. That's when we call it as ARDS. And here they said bilateral alveolar infiltrates, but they mentioned there should not be any effusions or underlying nodules or collapse of the lung. So they put a little sort of a tagline there or a disclaimer that they should not have any underlying other pathognomonic features in Berlin's definition. And of course, the edema, they said it has to be cardiogenic, but they de-emphasized on pulmonary wedge pressure and they said there should be echo evidence of no heart failure. And oxygenation was pretty similar to the previous, less than 300, they said mild, moderate is 200, but they put PEEP, that every patient should have a PEEP of more than 5 and they should fall in this category, which was not there in AECC definition. So this was the change that happened in Berlin's, and all our trainees here, we are following this at this point of time. Now we have started questioning because the limitation of this Berlin's definition is it doesn't take into account, it depends on blood gases and does not take into saturation, which we very commonly use, and especially in resource letting, we don't want outline for every patient, so saturation is not utilized. And most important limitations is in the COVID, we have realized the value of HFNO. So this particular Berlin definition excludes patients who are on HFNO. Now all of us know here that all our COVID ARDS were on HFNO. ARDS, we manage them on HFNO, and it eliminates because it does not factor in the fact that patients who are on HFNO can be taken as ARDS. And in resource limited settings, not necessarily we need to rely on X-ray because all the people who are present here, we are doing lung ultrasounds to determine pulmonary edema. So the focus was we should adopt B lines or any other sort of a B predominant lines to determine ARDS, and not necessarily you need X-ray or ABG or NIV or mechanical ventilation. Not necessarily they are available, and I'll show you some examples as to why we believe these things should be taken out of definition. So this was the reason why the global definition came. So there were more limitations like for non-cardiogenic pulmonary edema. For cardiogenic, you have NT-proBNP. For non-cardiogenic pulmonary edema, we do not have a single biochemical marker that can tell you it is non-cardiogenic pulmonary edema. And single PaO2 and FiO2 at diagnosis is a poor performance of including patients as ARDS. And lung mechanics are not factored in any of the definitions, like dead space and tidal volume ratio, which is like like a driving pressure, that is missing in the definition and prognosis. And PEEP less than 5 is inconceivable. And most definitions have not taken into consideration other sort of organ failures, because we are only looking at the lung. And all of you know ARDS can have other organ dysfunction also. Other organ failures are not involved in any of the definitions. And definitions have not taken into pulmonary vasculature pathophysiology or microthrombi BP mismatch into consideration. Pulmonary, and all of us know that ARDS develop pulmonary artery hypertension, and RV dysfunction is an important morbidity factor in ARDS, and none of these definitions are factored in RV dysfunction. And categorization, we all increasingly talking about phenotypes of ARDS, like who are the ones who are PEEP responsive. These are not factored in any of the definitions. And pathological underlying process of endothelial injury or biomarkers are not factored in. So the futuristic definition, the pundits believe that should encompass at least some of these salient aspects which define this cohort of patients with ARDS. And now we are talking about personalized medicine. So ventilation which are customized or which are calibrated to the etiology, to the lung physiology, to the imaging, and to the phenotype subclasses is something that, because AI is coming, and with the AI ventilation, we are trying to customize ventilation to the patient's needs of ventilation, and this has to be factored in the definition. So this is a Puritan thought as to what should encompass in the definition is what we have been thinking, and to that effect, to some extent, the global definition hopefully gives us answers. So now we'll talk about why we need definition, and this is a new global definition of ARDS. So what it tries to address is, tries to address the pathophysiology, tries to look into the etiological factors like trauma, burns, and aspiration and blood transfusion, tries to take into consideration the pathophysiological process of the alveolar exudates that happen leading to hypoxemia and compliance, takes into consideration the therapeutic modalities that we are using now with prone ventilation, sedation, analgesics, and fluid balance. So it tries to encompass as much as possible to try and see we have an altruistic sort of a definition going into the future of ARDS. So the new global definition came out in 2024 by, it came in AJRCC. It's a very new sort of a proposed definition by Mate et al. So what it tells, so the left column you see is the Berlin definition, the right column is the proposed new global definition. So what it says is the acuity last week, it remains. But it says even if patient has underlying chronic conditions like COPD, or even if they have ILD, so you should consider the possibility of them having a superimposed ARDS. So underlying condition should not exclude them from ARDS is the new sort of a proposition that has come. And bilateral infiltrates, as you see in the chest X-ray, it says you can use ultrasound. You don't need X-ray to say that it is ARDS. Even lung ultrasound showing B predominant lines or B pattern, if you believe it is non-cardiogenic, you can still call it ARDS. That is the new sort of a proposed global definition. And non-cut, this is very important. So nowadays I see all my patients in who come with sort of influenza pneumonia, they have pneumonia, but they have pulmonary edema and they go into ARDS. You cannot say that this is not ARDS, because after pulmonary edema is resolved, they can go into ARDS. So what the new definition says is they can coexist. Heart failure can coexist and infective component can coexist. You can still call them ARDS after the heart failure component has been addressed. This is very important practically for all of us present here, because all the influenza pneumonias I am seeing have a significant heart failure component along with the lung component that is affected. So you need to delineate, treat it, and then label it. If things don't improve after heart failure, you can still call them as ARDS. And this is very important. So they said you don't have to depend on ABG, you can depend on saturation. So they have defined as saturation SF ratio, like PF ratio. You can look at SF ratio, and as you see, it's very easy to remember. Slightly put more than PaO2, like mild SF ratio, mild ARDS, if SF ratio is 235 to 315, you have to remember 315, because less than 300 we call it ARDS. Moderate SF is 148 to 235, severe is less than 148. So this is the new global proposed definition. And the new definition also says you can consider patients who are HFNO and have ARDS as ARDS. Before, the Berlin definition ruled out HFNO patients, and not necessarily you need PEEP every time to say that patient is ARDS. Even without PEEP, if they are an HFNO of 30 liters per minute, you can still call them as ARDS. So this is the new proposed definition which needs to be validated in some of the studies. And they have said the saturation SF ratio has a good correlation with the PF ratio, and it has a good performance if saturation is less than 97%. And depending on SF ratio, it avoids frequent ABGs and emphasizes, and this new definition tends to emphasize on dead space and tidal volume severity, because we know increase in this ratio has a correlation with increase in mortality. And the future definition should try to encompass the phenotype of ARDS, trying to identify patients who are resistant to treatment, try to target patients who are amenable for aggressive and innovative treatment, determining patients who benefit from intubation and excluding patients from trials. Just to give examples of the new definition. So this is a 68-year-old male with septic shock. This is a typical ARDS who's on FI to 50%, PF is 150, you call it. So that is our old definition. And where we can apply new definition is, you have this lady with a breast cancer, COVID, pneumonia, worsening shortness. She's on HFNO. She's not an NIV. FiO2 of 80% and saturating 91. You have SF ratio as 114. So this you can call as ARDS, severe ARDS in the new definition. And this is a 39-year-old female with abdominal sepsis with gram negative in an area of need, in a resource limited setting. There is no X-ray. You have done a lung ultrasound. You have seen B lines. SF ratio is 142. Even this lady, you can call it as ARDS. So this is the new paradigm change that has happened from the Berlin definition, that you can include patients by doing lung ultrasound, and even you can include patients who are on HFNO. Just last 1 minute I'll take. So this is the conclusion slide. So the future definition, as how Puritans look at it, is they look at it as a bullet train or whatever train. So they have different components. So first thing is, any definition should look into all the etiological aspects, and the second one should look into all the therapeutic interventions that patient is on, like protective lung ventilation, PEEP optimization, and prone ventilation. And they should take into consideration not only the lung dynamics with biomarkers, imaging, and most importantly looking into the RV function, pulmonary hypertension. They should even look at the systemic organ dysfunction that is happening in the definition, like lactate, SOFA, biomarkers. And stratification has to be done based on the phenotype of the patient, as to patients who are resistive to treatment, and targeting the patients who would benefit from aggressive or innovative therapies, and excluding certain patients from trials. And other therapies, certain patients who may benefit only with NIV or ECMO or fluid balance, has to be encompassed in the definition. And the newer definition should be used to look at the short-term outcome at 7 days, long-term outcome at 6 months, and excluding patients from these studies. So this is the sort of altruistic definition that we wish to have in ARDS. So thank you, friends. Thank you very much. So request you all to submit valuable work to Journal of Acute Care and visit my website. Thank you. Thank you, Anandu. Questions at end of session? Okay. Thank you. Thank you, Anandu.
Yeah, Dr. Pradeep, excellent talk, short and very sweet. It's open for any suggestions. End of the session. Okay, done.